Hi rabbits, Research Turtle here. Today we are diving deep into a fascinating battle in nephrology. We're looking at the paradigm shift in treating chronic kidney disease, specifically for patients with low proteinuria. We're comparing the reigning champion, RAAS inhibitors, against the challenger, SGLT2 inhibitors. Let's start with the big picture. For 30 years, we treated CKD by managing hemodynamics, essentially blood pressure within the kidney. That was the era of RAAS inhibitors. But today, we are moving toward metabolic defense. SGLT2 inhibitors are changing the game by improving cellular energy and fixing hypoxia. Let's look at the standard of care. RAAS inhibitors, like ACEs and ARBs, have been our go-to. They work by dilating the efferent arteriole, relaxing the exit door of the glomerulus to lower pressure. But here's the catch. Their efficacy hits a ceiling effect. If a patient has low proteinuria, meaning they don't have high intraglomerular pressure, RAAS inhibitors lose their primary target. Their benefit in normoalbuminuria is historically uncertain. Enter the challenger, SGLT2 inhibitors. Look at the evolution of clinical trials. Early studies like CREDENCE focused on diabetic patients with high proteinuria, but EMPA-KIDNEY changed everything. It deliberately included patients with low or even normal albuminuria. And guess what? It worked. This proved that kidney protection isn't just about fixing pressure, it's about something deeper. Now, you might ask, is there a head-to-head trial comparing these two drugs alone? The answer is no. So to find the truth, we have to build a mosaic of evidence. We combine the level 1 data from EMPA-KIDNEY with massive real-world data from Korea and our understanding of biological mechanisms. Let's look at the stats. In EMPA-KIDNEY, the relative risk reduction was consistent, a hazard ratio of around 0.72 regardless of whether the patient had high or low albuminuria. However, we must be realistic about the absolute benefit. Because low proteinuria patients are generally lower risk, the number of events prevented is lower, but biologically, the drug is definitely working. Here's the most intriguing piece of the puzzle. A massive Korean cohort study of over 260,000 patients compared monotherapy directly. The result? SGLT2 inhibitor monotherapy showed superior survival benefits, reducing all-cause mortality significantly better than RAAS inhibitor monotherapy. This suggests that for survival, the metabolic benefits of SGLT2 inhibitors might outweigh the hemodynamic benefits of RAAS inhibitors in the real world. We also see this in heart failure trials like DAPA-HF. Even in patients without diabetes and without albuminuria, SGLT2 inhibitors slowed the decline of kidney function. This confirms intrinsic renal protection. So why does this happen? First, hemodynamics. SGLT2 inhibitors constrict the afferent arteriole, the entrance, while RAAS inhibitors dilate the efferent arteriole, the exit. Together, they create a perfect glomerular clamp, optimizing pressure. But slide 11 is the real key for low proteinuria, metabolism. SGLT2 inhibitors reduce the workload of the proximal tubule. They lower ATP demand and switch the kidney's fuel source to ketones, a superfuel. This fixes cellular hypoxia. This is why they work even when the kidney isn't leaking protein. Practically speaking, this is crucial. RAAS inhibitors raise potassium, causing hyperkalemia. SGLT2 inhibitors do the opposite. They lower potassium risk. This means SGLT2 inhibitors are the enablers. They allow you to safely use RAAS inhibitors without fearing dangerous potassium spikes. This brings us to the 2024 KDIGO Guidelines. Both drugs are now Class 1A recommendations. The question is no longer which one should I choose. The answer is combination. You use RAAS inhibitors for pressure control and SGLT2 inhibitors for metabolic defense. To wrap up, we are moving from competition to synergy. While the data suggests SGLT2 inhibitors are a formidable monotherapy, especially for survival, the clinical win comes from using them together. We don't choose, we combine. That's it for today. Turtle out.